We have a lot to cover today. But first, what do you get when you cross a vampire and a teacher? A vampire and a teacher. Blood tests. Okay. All right. So do you mind running up and seeing if you have another battery? There's no battery in here? Yeah, it looks like the battery's dead. Sure. Just improve it.
Yeah.
Okay. All right. Why did the snake go to the baby toy store? Why did the snake go to the baby toy store? So he could get a new rattle, or a little rattle. Okay, very good. All right. This actually is one that my youngest daughter made up a couple of years ago, and we were pretty excited about it, so I wrote it down. And it works way better with my microphone, so you're going to have to bear with me, okay? What is Darth Vader's favorite dessert? Darth Vader's favorite dessert. You ready? Okay. You guys catch it? All right. She actually made that one up. That was a proud dad moment. Okay. So I don't have a mic, so I have to yell, which isn't hard for me, but it's hard to keep it going for 2 hours at that volume. So we need to pick up where we left off with the endocrine system, and that was here. Okay? So with the endocrine system, what we didn't describe, or what we did not discuss, is the pancreas. And we didn't talk about specifically the one disorder that we're going to look at, which is diabetes mellitus. So in diabetes mellitus, it's uniquely different than diabetes insipidus, and that's one of the reasons that I was actually somewhat pleased that we had a nice delay and we didn't cover mellitus on the last exam, the second exam, because I don't like students to get confused. The diabetes insipidus is a dysfunction of, I think that's the microphone coming online. That's pretty funny. Hopefully they don't have to relieve themselves, because that would be awkward. Diabetes insipidus is dysfunction of what structure in the body? What target tissue? Diabetes insipidus. Posterior pituitary. Very good. You were close. Posterior pituitary. And diabetes mellitus, in contrast, or in comparison, is dysfunction of what target tissue? Pancreas. Pancreatic tissue. Specifically the beta islet cells. Thank you. Oh, man, that sucker's live. Okay. Let's turn that off. So diabetes mellitus is a problem associated with the pancreas. Diabetes mellitus in Latin is referring to, so diabetes, right? Diabetes is siphoning. Let's put this way down here. Let me pause a second. They're going to be way too loud. Holy smokes, dude. Go way down here. Is that better? Is that too loud? Sounds good? Okay. So diabetes, oh man. I might have to turn the gain down because this is, okay, there it is. Technical difficulties. Check. Check. That good? Is that better? Hello? Test. Right there? Yeah. Okay. So diabetes mellitus, in Latin, diabetes is siphoning, and mellitus is sweet like honey. Sweet like honey. So it means like siphoning off honey. So mellitus is almost a term of endearment, right? You can use it in February for Valentine's Day. Okay? You call your significant other your mellitus. Okay? It's sweet like honey. Doesn't sound as well in English as it does in the Latin. But it's siphoning off sugar. And the way that we knew what the problem was back when the early Greeks and the Romans were looking at the body and were describing conditions of diabetes mellitus is how would they do a test? How would they know that there was a problem with something sweet or sugar? What's that? The urine. Okay? The urine would smell sweet. I imagine it tasted sweet too. And although it is sterile, I think it's better maybe just to sniff it. Okay? So they would sniff the urine from the patient and realize that it smelled sweet because there was a lot of sugar that was being excreted in the urine. So that's how this disease state was named. Now we have two types of diabetes mellitus. We've got type 1 and we have type 2. Type 1 is referred to as the inability to produce insulin, and type 2 is typically the inability to respond to insulin. Now some of the older terms that you might read in some of the older textbooks is type 1 is childhood diabetes. Okay? But patients might present later in life with type 1 diabetes, in adulthood, in their 20s, or maybe in their teenage years. It's pretty common in the teenage years or in the early 20s for patients to be diagnosed with diabetes, type 1, and they were fine as a child. So what's going on there? Well, we'll talk about that in a little bit. And then type 2 is referred to as adult onset. Now these are old terms. These are not really used any longer. So childhood versus adult onset. And the reason type 2 adult onset is not as favorable anymore is there are examples of children that are type 2 diabetic. And you probably read about this even in the popular news magazines about the onset of childhood obesity. And obesity doesn't necessarily cause diabetes, and diabetes doesn't necessarily cause obesity. There hasn't been any proof to demonstrate that one causes the other, but they are very highly correlated with each other, meaning that patients that wrestle with obesity tend also to have complications associated with type 2 diabetes. Okay? And as we unfold the two different types of diabetes, it'll make sense. Now, there's technically a third type of diabetes, but it's transient, and it's called gestational. And gestational diabetes affects about 3 to 10% of the population, 3 to 10% of pregnancies, not the population, but of pregnancies. And there's really been no specific cause that's been identified, but it's thought that the hormones produced during pregnancy increases a woman's resistance to insulin. And therefore, it impairs glucotolerance. It would make sense in women if the infant, or I should say the fetus, is pulling nutrition from maternal blood, that you don't want to starve the maternal blood of sugar. So you want to try to keep it well sugared, okay, so that the fetus can actually pull glucose from the maternal blood. Okay, so that makes some sense. Okay, hold your questions for a little bit. Okay, I want to look at this diagram and kind of characterize what we see with diabetes, and then we'll get to some questions in a minute. This kind of cuts off because of the screen, which is kind of weird. I don't know how to adjust that. But if you've got 3 different target tissues of insulin, you've got fat, muscle, and liver. And we're going to see in today's lecture that all 3 of these organs can be influenced by either insulin or glucose. And with striated muscle, so I'll read this so you can actually appreciate it. This says an increase in glucose uptake, an increase in glycogen synthesis, there's a storage form of glucose, and then an increase in protein synthesis. That's what insulin does in skeletal muscle. Also in heart. okay, so striated muscle. The liver, it lowers gluconeogenesis because it needs you have plenty of glucose. Gluconeogenesis is the production of new glucose, right? Sugar new beginning, that's what it translates to, right? Gluconeogenesis. Sugar, neo is new, and then genesis is beginning. So it lowers the production of new sugar because you don't need it. It increases the storage form of sugar, which is an increase in glycogen synthesis, and it also increases lipogenesis, or the production of new fat, as a storage form of fuel. So insulin has all sorts of unique activities as you look around the body. Now, if we wrestle with glucose levels and we want to diagnose these patients, we actually can do this a couple of different ways. Now, normal glucose is between 70 and 120 milligrams per deciliter, okay? Milligrams per deciliter. And if you have over a 200 mg per deciliter draw, you would be considered, this to be at random, you'd be considered to be in a diabetic risk factor. Or you can have a fasting glucose level of 126 mg per deciliter, or it could be higher. Or you could test abnormally on an oral glucose tolerance test. So how is a glucose tolerance test done? Well, the most common version of the test looks something like this, where you actually give a standard dose of glucose orally, and then you measure blood levels later and see what those sugar levels are, okay? Now, sugar is going to fluctuate throughout the day. I'm not a nutritionist, okay? Although my undergraduate degree at the U of A was in exercise science. How many of you are exercise science? Okay. And as exercise science majors, we actually had a whole bunch of nutrition courses that we had to take. And even back then, like, pre-fire is when I was in undergrad, right? Caveman days. We knew that eating smaller meals but more regularly throughout the day was healthier for you. And the real reason it was more healthy is you minimized the amounts of hills and valleys between high sugar levels and low sugar levels, okay? So I'm just going to go out on a limb. Last Thursday, many of you probably had a monster peak at around noon, or maybe it was like 3 p.m. or 5 p.m., depending upon when you eat your Thanksgiving meal. But there was probably an abnormal peak beyond what's even on this chart because of the Thanksgiving holiday. Okay, so if you can see here, we usually have a break fast, we break the fast, right? And we have our early meal, and then we get a spike in blood sugar levels. And then right around noontime, or looks like here it's like 1 to 2, we get another spike. And then around dinner time, this is 7 p.m. dinner, so it's a little later for some of us, but you can see that there's this 3 peak per day. And what you can appreciate is that there's a red peak, which is your sugar level, and then there's a blue or kind of like a purple peak that is almost overlapping it, or slightly delayed, almost instantaneous when you see that peak. And that's your insulin release. And so your body is controlling those sugar levels to try to bring those blood sugar levels down, so the sugar isn't floating in the bloodstream, it actually is moving into cells where it can be used. And if it's going to move into a cell and it's not going to be used immediately, then it's stored as glycogen, which is the storage form of glucose. You guys with me? Okay. Question over here.
No, it was just a question about something that you said. Was it third or 2/3 that you said about gestational diabetes?
3 to 10%. Yes. Okay. So if we look at pathogenesis of type 1, how it occurs, it's an autoimmune disease. Type 1 is where you have CD4 and CD8 cells that are attacking the beta islet cells of your pancreas. And when we're younger and we have an autoimmune attack, we may not completely destroy all the beta islet cells. And so maybe a population of the pancreas is actually compromised. So in type 1 diabetics that aren't diagnosed until maybe they're 25 years of age, right? And some of you some of us scratch our head going, I thought this was childhood, and they're well beyond childhood. Well, it might be that when they were younger, it was a slow attack on the pancreas, and instead of 100% of the pancreatic beta islet cells being killed, maybe like 70% of them were attacked, okay, and 30% were remaining. And as a kid, your parents don't manage your diet pretty well. And so it was under control, if you will. And in the teenage years, when you have growth and you have puberty that takes place, there's larger body mass, right? You go out on your own. It's pretty well established that healthy foods are far more expensive, okay? And that's why college students don't eat as healthy, because you don't have all the resources that you did when you were growing up. And so now you move into maybe more quick foods or fast foods, less quality foods, more sugars, and that challenges the system, and the number of pancreatic beta islet cells is dropping. And so that could be one of the reasons that there's this inflection point of beta islet cells that are dying, okay, and your sugar challenges that are going up, and it materializes itself in late teenage years or early 20s. So that's an example of how a type 1 diabetic, which is classically referred to as childhood onset of diabetes, doesn't develop diabetes until they're older, okay? And it may not have anything to do with the diet, it might have more to do with the slow progression of the disease as it destroys the beta islet cells. But then you just wind on top of it. It's usually a combination of what's going on genetically is what's happening environmentally. So there's some combination of the two. Question?
Can gestational diabetes turn into a type 1 or 2 or type 1, I guess? Or would it just like present as gestational?
So gestational diabetes can actually continue. It's usually continuing into a type 2 situation. We're going to talk about type 2 in a second. Okay? So in this case, with type 1 diabetes, when 80 to 90% of the beta cells are destroyed, that's usually when the patient becomes symptomatic. And then they'll have blood glucose spikes. Instead of, in a 120 or maybe a 150 range, it might be like 300 or 400. Okay, I've seen clinical cases be as high as 700s, and these patients are passed out in an ambulance to an emergency department. Okay, example, young healthy kid, a family friend, he was a basketball player, tall, skinny, kind of classic morphology of a basketball player. 18 years of age, just finished high school, had a scholarship to go play like Division II basketball at a school, was at the boardwalk in Santa Cruz, okay, over the summer before school started, and decided to have 3 funnel cakes at the boardwalk. 1 is a lot of sugar, okay, but 3 is, like a death wish. And literally, this individual, unbeknownst to him or his mom or any of his family members, didn't have diabetes, went into a sugar coma, and a level of 700, a blood sugar level of 700 is what they actually measured him at the emergency department. He survived, everything was fine, now he's on insulin, but never knew what was going on until that one point. And that was the trigger that challenged the system. It was probably because up until that point, enough of the beta cells were there, but now he's out of high school, he's getting ready to go to college. He makes a decision. I mean, what parent in the right mind would say, oh, how many funnel cakes have you had? 2. Would you like to have another one, sweetie? Like, usually they're going to say, that I think, 1's enough. I didn't even know you bought that. So he was right out of high school, getting ready to go to college, made his own adult decision to have 3 funnel cakes. Didn't know he had this underlying disease state, and that's what pushed him over the edge. Okay? So, kind of an example of how this might manifest itself. There are B cells that are involved. There's no question about that. There's antibodies that are produced against those beta islet cells. But because of the role of the CD8 cells and the cytotoxicity, we classify this as a type 4, a type 4 hypersensitivity. So you can kind of appreciate from these cartoon drawings, a healthy pancreas is shown here. It's going to make little green dots, which are the insulin. It's going to bind up the blue dots, which are sugar molecules. And I don't always cut off. Does it always seem like it was cut off, or is this new? That's kind of new, isn't it? I didn't have too much turkey. Let's see if I can do something with the screen. Display tools. There we go. That bugs me. Can't tell. It's probably above my pay grade to be able to change that, huh? Okay, so we won't mess with it. I'll just have to explain to you what's down here. Unless somebody wants to climb up there and push that apparatus up a little bit, but that's probably bad. Okay. So down here, what we're seeing is the activity on cells. These are little cells right here, and the sugar molecule is going to go basically into that cell. Over here, we've got the immune system destroying the pancreatic beta islet cells. No glucose or no insulin or very low insulin is made, and so the sugar is plentiful, but it's not able to uptake inside the cell. So what do these patients wrestle with? Well, they've got the 3 P's. And so we can talk about this in 3 P's. We can talk about it as polydipsia, excessive thirst, polyphagia, which is excessive eating, as well as polyuria, which is excessive urine production. So why are they happening? Well, excessive thirst, right? You've got increased blood glucose. That leads to an increase in blood osmolarity. That increases the blood volume, and it decreases intracellular dehydration. So now you've got the thirst centers in the hypothalamus being stimulated, and the patient feels thirsty. Polyphagia, well, the bottom line is there's plenty of sugar, but it's not making it into the cell. And so the patient feels hungry on a continuous basis, polyphagia. And polyuria, large productions of urine. Well, you've got saturation of the glomerular apparatus within the kidneys, and specifically saturation or coating, sugar coating of the proteins. And so this causes glucosuria. So you got sugar in the urine, bless you. This increases the osmolarity of the urine. You lose water because water follows solutes. So the water rushes out of the kidney tubules to where there's high sugar in the urine. And then the thirst centers are stimulated because you're losing large volumes of water. Okay? We get rapid weight loss in these patients. This is because you've got high fluctuation of sugar levels. So the body can't depend on that nutritional source. Ketoacidosis. This is a term, it's a metabolic term that refers to when you switch to a different form of energy. So this is the breakdown of fatty acids and the deamination of amino acids. So your body's saying, if I'm not going to have sugar as a source of fuel, I'm going to move to fat and I'm going to move to protein. And so ketoacidosis, the ketone bodies that are actually produced are a metabolic waste product that comes off of fat metabolism as well as protein metabolism. Okay? And those ketones can build up in the bloodstream, and if you're not careful about it, it can actually lower the pH or cause an acidosis of the overall system. And that can actually, it can be lethal if it's not kept under control. Then the last one on this list, and we have a couple questions, is hyperglycemia. So patients become hyperglycemic because the sugar is floating in the bloodstream and it's not in the cell. So the amount of sugar in the bloodstream is too high, and that's the hyperglycemia that's present. It's not because there's not enough sugar available, it's because there's no way to transport it into the cells that need it. Question up front?
Yeah, so for the weight loss, is that why they should just
Why the weight loss?
I would say one of the lines as to why explains why obesity and diabetes should really cause a direct correlate causation.
So there's not a cause and effect necessarily, but again, we're talking about type 1 diabetes here. This isn't type 2. So you do see a lot of obesity in type 2 patients, but that's because of another reason. That's because type 2 patients usually are consuming large they have a high caloric intake, and they have a lot of sugar that's coming in. So it's a different modality that we'll talk about in a second. But with type 1, you don't necessarily see a lot of obesity associated with type 1 diabetics that are underage. It's the opposite. You will lose weight.
And
Go ahead.
for the ketoacidosis, is that like related to like the ketogenic diet where they want you to go into that sort of process to lose a lot of weight?
Yeah, so a lot of the fad diets, okay, they're all the same, just so you know. Okay, there's nothing new. They've been around since the dawn of man, because it's your body's way of keeping itself alive. And so in our Western world, it's a luxury item to say I'm going to go on a diet, right? It's a first world problem to say I'm dieting, right? Oh, I had Thanksgiving last week, poor me, now I got to lose some weight. Nobody else in the world feels sorry for it, sorry. You know, I mean, it's like that's a first world problem. So ketoacidosis, a lot of these fad diets are basically saying, okay, we're going to trick the body into burning fat that I have stored, and I'm going to restrict carbs, I'm going to restrict sugars, right? You see what you're doing? So if you don't bring in a lot of starches, sugars, and even complex sugars, and you stay away from the carbohydrates, which are the sugars, you're going to have to find fuel from another source. So you're going to burn fat, and you're going to burn some protein, just so you know. They say, oh, we'll supplement it with protein. Well, that's great, but your body does need sugar to survive. And so in the absence of sugar, you will actually convert a lot of the fuels that you actually have access to. You'll convert it over to sugar. So you still have sugar on board. So a little bit of sugar isn't necessarily a bad thing. Okay? And a lot of those, in my opinion, again, I'm not a nutritionist, not a dietitian, not registered or licensed, but a lot of those diets can be very dangerous. Right? And there's a reason when you're on those diets, like you feel foggy and you feel lethargic, and it's not a great time to take an exam. Well, the primary source of fuel for the brain is actually glucose. And so if you're not providing enough sugar, it's going to be difficult to actually have high brain function, just as an FYI. So you can write a book on how to lose weight, okay, or I could write one and say just eat less and burn more calories than you bring in. And there you go, book signing out in the lobby. Anybody's welcome. They're all the same. I mean, it's not that complicated, right? But yeah, your question about ketoacidosis is a great one, because that's burning fat or burning protein instead of burning sugar. Okay. Last question, then we got to move on.
So the 3 P's, you said polyuria, polyphagia, and what's the third one?
Polydipsia.
Polydipsia. And my second question was when you have diabetes, when you have ketone bodies, your brain is not affected by diabetes. Your brain is still consuming glucose as a first
Source.
correct?
Yes, that's correct. Yep, so you got to convert it. Okay, now let's switch to type 2. So type 2 is where your questions come in here. So why is there this close association? Some would believe, inappropriately, that there's a cause and effect. If I'm obese, I'm going to have diabetes. Or if I have type 2 diabetes, I'm going to be obese. Why does there appear to be some cause? There's no cause and effect, but why does it appear that way? Well, it appears that way because there is a high correlation between patients that are morbidly obese and those that end up developing symptoms of type 2 diabetes. And this is because it really foundationally depends on resistance to insulin. Okay? So I'll give you an example. Conditioning. If many of you are, let's say, used to consuming a certain type of pain medication, okay, this is also another topic that's difficult in our society. But let's just say that it's ibuprofen, and you develop either aches and pains, or you develop a headache, and maybe you reach for like an Excedrin or an ibuprofen or a Tylenol, acetaminophen. And after about 6 months to a year of that, you start to realize that one ibuprofen is not enough, and so you take 2. Instead of 200 milligrams, you take 400 milligrams. You're starting to build up a tolerance or a resistance to that medication. You could substitute any kind of pharmaceutical, like alcohol, in for that analogy. Okay? And you know, the single glass of wine or the one beer, it used to be that you could only have one, and then you couldn't even figure out which way the door was. And maybe after you do that for a while, you start building up a tolerance, and now you feel like you can have 2. Then after a while, it's to 3 or 4, and that's where it becomes potentially dangerous. So same thing happens with insulin. Is if you flood the system with lots of insulin. You remember that chart where 3 times a day, classically, we have these huge peaks? And so if you think about that chart, and you've been doing that for 50 or 60 years, and it's like you wait, from the time you go to bed to the time that you wake up, well, you haven't eaten anything, but your metabolism goes way down. Then you have a huge meal, okay? And then you heat the system full of insulin. And then you don't consume any calories all morning, and you have like a 2 o'clock lunch, and at 2 o'clock you're famished. And now it's this big peak. And then you wait, you go until like 9 or 10 o'clock at night, and you finally have dinner, and it's this huge meal, and then you go to bed. Well, some of the things that are going to be happening over time is that big meal at the end of the day, most of those calories are going to be unused because you're going to bed. You're not going to be burning as many calories when you're sleeping. Okay? So that's where caloric intake has increased. And after 50, 60 years of doing that behavior with a big meal at the end of the day, which is mostly what we do in America and the Western world, most of those calories are going to be unused calories until the next day. And your body's going to save them and store them, and you know exactly where it stores them, right? So that's one problem that we have going on. After 50, 60 years, we slowly gain weight. So the individual gains weight. Maybe it's only 5 pounds every 2 years, okay? But 5 pounds, every 2 years over a 20-year period, that can end up being, a reasonable amount of weight, or a 30-year period, or 35 years of 5 to 6 pounds per year of gaining weight. So that's where the obesity comes in. Now, the other thing that's happening is you're peaking the system systematically 3 times a day with high amounts of insulin. And over that 50, 60-year period of time, you become less sensitive to that insulin. And it takes a little bit more insulin to have the same effect of bringing that sugar into the cell. So this is our insulin resistance. And so the etiology is the clinical sequela is usually, or the description is, usually it's slightly older than middle-aged, okay? So you're talking about 50 to 60 years of age of when type 2 diabetes sets on. This used to be the norm, okay? Most of those patients tend to be overweight or morbidly obese, okay? So that's where this cause and effect appearance seems to have shown up. But we've also learned that there are potential genetic involvements. It's not all environment. Imagine that, it's not all environment, right? Is anybody surprised when I tell you it's not all environment? It's not just your behavior over those 50 to 60 years. Okay? There's an underlying genetic component that likely is at play. So for some of us, if we do what I've just described, and you threw smoking in there, you may never develop lung cancer, and you may never develop type 2 diabetes, right? And for others who don't smoke, they might develop lung cancer. And those that just live like a normal Western life, right? But that involves meat and potatoes at the end of the day, correct? Might develop a type 2 diabetes. So there's going to be some genetic predisposition to it. And so what we've learned over the years is there does look to be a genetic defect that can occur in the insulin receptor and or the insulin signaling pathways. And as we age, a lot of these defects tend to materialize when they weren't there when we were younger. Okay? So this is a resistance problem, and you can actually see on these little cartoon diagrams, and we'll take some questions. If this is under normal conditions or when the patient was younger, you can see the amount of little green spheres that are being released. That's the insulin binding to the blue spheres. That's the glucose. And there's enough there to bring it inside of the cells. Over here, you have fewer insulin products that are being released, and or you become resistant to the insulin that's being produced. Okay, so it might be the same amount that's here, but maybe the insulin that actually is made has a defect in the receptor of where it's going to bind on the cell. Okay, and if the cell down here has a defect in the insulin receptor, the insulin that binds there or wants to bind there may never find the receptor. It may not actually bind. And even though there's enough insulin, it may not actually bring the glucose inside of the cell. Okay, there's a question. Yes?
Is it fasting insulin level, or here, each one, the A1C test, diagnosing type 2, which is the...
Yeah, so usually they're looked at in combination. Okay, so you're gonna look at the glucose levels, right, as well as the insulin in combination with each other. So that's the more normal thing to do today. Okay?
That's it.
What's that?
Instead of hemoglobin A1C.
Well, so they'll use all three diagnostic tools. Yeah.
Or it's fasting.
Yeah, usually it's always a fasting test. Okay? Okay, so symptoms of type 2. And this is where a lot of our challenges clinically tend to show up. And most of you that move on into a clinical realm are going to be seeing patients that really fall into this category of type 2 diabetes mellitus. Okay? Why is that? Well, a lot of the metrics are pushing the patient population in this direction. Okay? Really, the number of type 1 diabetics is not really changing that much. The age of the population numbers are going up, right? Our world population is increasing, but the relative percent of type 1 diabetics is about the same. The absolute number is more because there's more people, but the relative percent of type 2 diabetes is increasing, which tells us one of two things. Not just that the population is increasing, but the relative percent is going up. That means that the disease incident rate is increasing. And so either we're becoming less healthy, or the genetic abnormalities are increasing, or some combination of the two. Okay? It's probably the latter of all of that, some combination of the two. But in these patients, they tend to be overweight, maybe even obese. And the reason for that is what I just described, which is their eating habits. Right? Not necessarily smaller meals more frequently, but 3 large meals or 2 large meals, and there's these monster spikes where they're consuming large amounts of calories. Dyslipidemia, that's an abnormal amount of lipid. That's our high fatty diet that we have in the Western world. Hyperinsulinemia, that's excessive levels of insulin in the blood. So we're making too much insulin because we have so much sugar that's floating around. Hypertension, fatigue, recurrent infections, and paresthesis. Now the hypertension, if you have a lot of sugar in the blood, there's a lot of solute there, so you're going to retain a lot of water, and now you're going to have higher pressure inside the bloodstream. Okay? Fatigue, they're tired because they don't have sugar that's coming into the cells. It's actually staying in the blood, so they're not able to use the energy. And again, the number one fuel source of the brain is actually sugar, glucose, in the form of glucose. Recurrent infections and paresthesis. So this gets us into the next phase of type 2 diabetes, which actually is a segue into our last lecture, which isn't the second half of today. It's actually next week when we talk about the cardiovascular system. So type 2 diabetics that are unmanaged have a lot of vascular abnormalities, a lot of vascular disease. If that sugar is present in the bloodstream, it's going to bind to things on the surface of the endothelium. Okay? So on the inside lining of the blood vessels, it's going to essentially sugarcoat it. And that's going to be problematic. Now imagine high sugar in the blood. What's that going to do to viscosity of the blood? Does it make it more viscous, or is it going to make it less viscous? Think about water versus maple syrup. Okay, maple syrup flows much less fast than water. It's a much higher viscous material. There's a high sugar content. And so if you have a high sugar content in the bloodstream, you'll have a higher viscosity. You also have, sugar molecules that can bind to a lot of proteins that are found on the inner lining of the bloodstream. So now you have these blood vessel diseases. So you have poor distal perfusion, and you get these wounds that show up on the feet, these diabetic foot ulcers, and they become infected because they can't heal. Paresthesis is that pinprick feeling, that numb and tingling of your like when something goes to sleep. That's the real term is paresthesia, the clinical term. And so that's a sign, that's an early sign that the nerve dying. So when a nerve is being starved of oxygen, it actually signals to you that I'm not happy, and usually you adjust your leg and you move into a different position. So that paresthesia is getting your attention. Now patients that wrestle with 24/7 paresthesia have difficulty sleeping. Can you imagine? Wouldn't that be absolutely horrific? Okay, so how do these chronic infections and how do these paresthesia issues happen? Well, this is diabetes mellitus, okay? But it could be ubiquitous. It could be either type 1 or a type 2 patient that's unmanaged. Typically, type 1 patients are pretty good at managing their symptoms for the most part, but not always. Okay, so if they're not managing their symptoms, they're going to display a lot of similar problems as a type 2 diabetic. But they've got these issues associated with advanced glycosylated end products. So ages, that means they're sugar-coated proteins. So collagen, for example, that's shown here. Collagen becomes cross-linked and it turns into a fatty protein that accumulates. The plasma proteins bind to these age receptors, these sugar-coated proteins, and they cause all sorts of problems within the blood flow. And then last but not least, protein kinase C activation. Protein kinase C activation can be stimulated, right? So protein kinase C can be stimulated, and this turns on these pro-angiogenic molecules like VEGF. And if that's going to happen in the eye, then you have within the eye itself abnormal blood vessel development, which is what's referred to as this diabetic retinopathy. So how do these sugars cause problems? If you have too much sugar in the bloodstream. Well, this polyol pathway is one that I want you to understand, and we'll walk through it in a few steps. It looks complicated, okay, but after we explain it in kind of, broad brushstrokes and get into some of the details, I think it'll be a little bit easier to understand. So if you take sugar in the form of glucose here, it can actually be converted. You can't read this because it's on the base of the screen, but it says fructose. Okay, so it goes from glucose to fructose through this polyol pathway. And this intermediate of sorbitol is converted to fructose. So some tissues don't even require insulin to bring sugar up as a transport. So like red blood cells, the kidneys, blood vessels, the eyes, the lens, nerves, none of these tissue targets or cells require insulin for glucose transport to bring glucose in. So if you have high sugar present, all of these cells will be influenced with this polyol pathway. So what we see is we've got hyperglycemia that's going to lead to high levels of glucose in these tissues. You get an intermediate of sorbitol that forms. That's the polyol, the sorbitol. And it's converting to fructose. Fructose increases the intracellular osmolarity and the intracellular osmotic pressure because there's a high amount of fructose inside the cell. And with a high amount of fructose, which is not the storage form of glucose, now you get a lot of fluid rushing into the cell and causing the cell to swell. And you can actually destroy the cell or cause permanent damage through high levels of fructose inside the cell.
Is that the cause of some of the food source of diabetes?
Yeah, it's the cause of a lot of nerve damage. A lot of nerve damage is taking place in the peripheral vasculature. And the problem with diabetics, type 2 diabetics, when they get this paresthesia and then they can't feel their legs anymore, so that's where it goes. It numb and tingling, and then it goes to I can't feel my legs anymore. They step on a carpet tack, where they bump the bottom of their bedpost, and their foot is not well vascularized to begin with, and now there's a sore that forms or a wound. It splits open. They don't even really know it's present because they can't feel, because the nerves are dying. And the only reason they know is when they put their sock on and off, they see blood. And now they go to now becomes infected, and it'll never close. Okay? And where that progresses is if it becomes infected, they'll have to amputate that portion of tissue. And that's why you see a lot of type 2 diabetics that are unmanaged diabetics that have never gotten control of this. They'll either have digits that are amputated, or their foot, or the lower leg. We try hard, the field tries hard to stay below the knee, because it's much easier to fit for a prosthetic if you stay below the knee. That knee joint really helps with prosthetic attachments. And as much of a stump as possible, so you have something to attach it to. But these are not great solutions, right? These are just trying to put Band-Aids on the problem. Okay. The other systems that are affected, we've got vascular disease, like we talked about. A lot of that sugar that's floating inside the blood is going to cause these collagen molecules to be sugar-coated. And now you get itises, or locations where disease can actually build. And we'll talk about vascular disease next week when we look at the cardiovascular section. Diabetic neuropathy. This is the nerves that are damaged through that polyol pathway that we just looked at. And then diabetic nephropathy. So this is kidney disease, because you've got a vascular disease within the kidney glomeruli and the capillaries that perfuse the kidney. That's why a lot of type 2 diabetics have end-stage renal failure. So if we look at histology of these vascular elements, this is advanced glycosylated end products, right? So this upper image, this picture on the right, this histology, is showing the renal cortex with a thickening of the basement membrane. And that thickening is because you've got all these glycosylated proteins that are happening in the basement membrane. So this thickened pink stain, it really should look like these thin structures over here. And so this thickening right here is because this is all glycosylated. And it should have a thin ribbon appearance like what you see over here versus these thick basement membrane stains. So if it's affecting vessels of the eye, it can lead to blindness. Vessels of the kidney, renal failure. The nerves die, and that's the neuropathies. And then the eye disease. The eye disease is a combination of advanced glycosylated end products within the vasculature that perfuses the eye, and then another problem associated with the protein kinase C being turned on, where now you get VEGF production, and you get blood vessels growing in places where they're not supposed to be, out of control. And that's the retinopathies. You get too much vascular growth within the retina, and then you can't see through it. Microvascular disease, so that's all micro, and then macrovascular on the big level, you've got coronary artery disease. So in these patients that have dyslipidemia or high fat in their diet, and they have these vascular lesions on the blood vessels, now you've got sticky inner lining of the vessel where the fat can actually attach to. And that's going to lead to atherosclerosis, which is what we're going to talk about next week. Okay? A couple questions here, just a second. Where does this go? Atherosclerosis. If it's targeting the heart, now you get myocardial infarctions or heart attacks. If it targets the vessels that perfuse the brain, then you have strokes. You might have transient ischemic attacks first, and then full-blown strokes as things progress. Okay, pause there. There's at least 2 or 3 questions that I saw. In the back first.
Can the HEEs reduce membrane thickening? Can that happen in all the different places, like the glomerulus and the renal and the different tissues?
Yeah, the advanced glycosylated end products can happen all over the body in the microvasculature, as well as in the macrovasculature. So the small vessels are micro, and the larger vessels are macro. So it's happening everywhere. We're just targeting areas that tend to be more problematic, where things show up first.
Okay, so when it comes to when one becomes affected in a diabetic patient, didn't we study when we were talking about inflammation, recovery, and regeneration, didn't we study that we can actually heal those?
So there was a technology that we talked about. So the question was, we talked about diabetic foot ulcers. Didn't we say that we could heal them? So the technology that we talked about with diabetic foot ulcer treatment was a product called Dermagraft. And there's lots of different technologies on the market to try to target and heal and close diabetic foot ulcers. And the answer to that is yes, some population of them we've actually gotten better at closing and healing. Wound vacs work really well. There's a lot of dressings that have silver that have antimicrobials in them that work really well. But we're still missing a large percentage of those populations that aren't healing. And some of them are because those technologies are expensive. So it's an access issue. Right? So some patient populations, even in this country, don't have access to all of the best technology.
And my second question was, when it comes to the Polyol Pathway, do you want us to know the names of each and every sugar type to the product?
No, just the sorbitol, which is the polyol, and then glucose in the beginning and fructose at the end. Great question. Yep. Okay. We're almost done with this section, then we'll take a break. Diabetic neuropathy, right? Through that polyol pathway, we have nerve damage that takes place, like we talked about. And that can affect lower peripheral vasculature and the lower extremities, right? And so it affects the lower extremities where we've got atherosclerotic disease and we have nerve damage down there. You may not feel that wound that's there. So it's a little bittersweet, right? It doesn't really hurt because you can't feel it. But an infection down here is going to turn that limb gangrenous and likely lead to amputation. And in the cases of the patients that we can't help, the sad truth is a lot of these technologies are far more expensive than amputation. Yeah. Unless you look at the clinical impact over the life of the patient and quality of life. But most of the studies only look at what is the cost to the hospital of amputation versus the cost to the hospital to treat. Right? So where we can make a huge impact is if we build into it, well, if you save the limb, and now the patient doesn't have physical therapy, they're not wheelchair bound, right? They can actually keep a job, they can, that's where all of the dollars and cents add up. But that's not how a lot of these decisions are being made right now. Okay, why do they get infected? Well, there's a high glucose content, right? That high glucose content causes perfusion problems. And in order to heal the wound and keep it closed so that a bacteria can't get in, you need vascular supply. So your blood vessel is compromised. There's an increased glucose that impedes oxygen release from the red blood cell. High levels of glucose actually prevent the oxygen molecule from coming off of the iron within hemoglobin. And so now your transfer of oxygen is minimized. Not only do you have low blood perfusion, you actually have a difficulty with the blood that you do deliver releasing the oxygen molecule so that the target tissue can actually receive it. All right, let's not end on a bad note. Let's talk about treatment, okay, and intervention and mortalities. So, with type 1, we can do insulin as an injection. There are research studies ongoing, but what is one of the biggest limiting reagents as to why insulin is not delivered as a pill today in mass quantities? There are clinical trials, but nothing has yet been approved for mass commercialization. Yes?
Because it's like direct to the blood vessel, it's like quicker.
It's a half-life issue. So if you inject it into the hypodermis and it gets into the vascular supply quickly, it can have its activity in the bloodstream. By ingesting it as a pill, it takes longer for reabsorption to take place. Okay, so you can't respond quickly after a meal. If you take insulin with the meal, it's going to take hours before it acts versus seconds to minutes.
What if HCl in the stomach like deform it?
So the acid could break it down. From what I understand, like the insulin molecule should be able to survive, and it won't denature it. But that is a potential limiting factor, is the harsh chemical environment of the stomach, right? And also release profile. So if you build a pill, how quickly can you release it and absorb it before it actually becomes denatured or compromised? Now with type 2, in some circumstances, insulin is delivered for type 2 diabetics, okay? It might be that you make insulin, but the receptor is mutated, or you make a mutated form of insulin. So if you gave you a synthetic insulin or recombinant insulin, you might actually respond to it quite well. And so some type 2 diabetics are being treated with insulin injections. And that's why this line gets a little fuzzy for students. It's like, wait, if you're injecting insulin, I thought you were a type 1 diabetic. Not always. It might be a type 2 diabetic that's responding favorably to exogenous insulin injections, okay, recombinant insulin. Some of these drugs for type 2 diabetics can be oral because it could be a more slow release profile. It doesn't have to be instantaneous. And then for both populations, it's a diet modification, and we prescribe exercise, right? This is where the exercise scientists should give a shout out. So why is exercise prescribed? Seems like, for everything, you go see the doctor. Yeah, I want you to eat better, and I want you to exercise, right? Yeah, but I was wrestling with Alzheimer's. Oh, I know, I just want you to have a better diet and exercise. Okay? It seems like they prescribe diet and exercise for everything. Here it actually makes a lot of sense, and it is a good lifestyle thing as a physician to be talking about diet and exercise, because we could probably always improve, especially in the western part of the world. Bless you. But if you look at this figure, you can kind of understand that for those cells that typically use glucose transport outside the cell to bring it in through insulin, exercise has been demonstrated to increase the concentration or upregulate the number of GLUT4 receptors that go into the cell, particularly in exercising muscle. Okay? So in skeletal muscle, GLUT transport or glucose transport via GLUT4 will go up with exercise by inserting, you can see here, there's inserted new glucose transporters, these GLUT4 transports. Here's the GLUT4 that's actually being manufactured by a secretory vesicle. Now it fuses with the membrane, and it inserts into the membrane ability for glucose to come into the cell that bypasses the insulin receptor. So with increasing exercise in our patient population, we increase the readily available glucose transport mechanisms that are not insulin dependent. And that's why exercise can help manage some of those high peaks in sugar. And so if a patient is exercising on a daily basis and they're increasing the number of GLUT4 receptors inside of their skeletal muscle, and they're managing their diet, maybe they're eating 4 or 5 smaller meals a day, so they don't have these huge peaks, and now that sugar has the ability to get inside the cell, okay? That's a great way to help manage some of the symptoms of unmanaged diabetes mellitus. Okay, question. Up front.
Because you said that type 1 people need more immediate acting, like something like this, versus like if you go on, or type 2 for exogenous insulin, or things like that. Is there a particular reason other than just the fact that they need to be lowered immediately because of, so they don't go with something like that sugar, basically?
So yeah, I mean the strategy for sugar management is you want to take that peak and you want to drop it down to more normal physiologic levels as quickly as possible. So the injections are still the fastest way to do it. Yeah, it's just the fastest way to do it. I've always kind of thought that like sublingual, like a sublingual delivery would be quite interesting. There's, believe it or not, there's research being done by Google. Google has actually funded research on intraocular contact lenses, that monitor sugar levels through your tears, and then will deliver insulin basically intraocular. Yeah, which seems rather painful, right? You're like this. Like, oh, sorry. Oh, you okay over there? Yeah, seems like, and the monitoring maybe not so bad, but the delivery, I don't know. Sorry, I cut you off. What's that? It's an oral pill. Yeah, there's literally like dozens now that you can choose from. A pill, like a daily pill. Yeah, but they're still kind of boutique-y. They're not for wide clinical use yet. And as part of it is because their label indications are very specific. They're only for very specific patient populations wrestling with certain types of diabetes type 2. Okay, let's go back here, and then we'll come back up here. So in the very back.
So with a lot of bodybuilders, for example, they would go on diets where they eat 4.
With who? Sorry.
Bodybuilders.
Bodybuilders. Okay.
They would go on diets where they eat 4,000 or 5,000 calories a day.
Okay.
So how does that affect their insulin level? Because I'm assuming it'll be piped throughout the day, essentially, because they're consuming a lot of foods, like 5, 6, 7 times a day.
Yeah, but a lot of that. So bodybuilders are consuming high, like large caloric intake. Same thing for a lot of athletes, not just bodybuilders. Football players do the same thing.
Swimmers too. Right.
Swimmers, marathon runners. You know, so if the caloric burn is keeping up with the caloric intake.
But wouldn't that affect their insulin resistance?
Well, it could, and if their nutritional coach is doing a good job, they're not going to tell them, I want you to eat 2 monster 3,000 meals per day. They're going to say, I want you to be eating like 8 meals a day. Like what? Like snacking. Bigger 3 meals a day, and I want you to, at like 10 o'clock between lunch and breakfast and lunch, I want you to have, a quarter of a pound of nuts. I want you to have dried fruit, right? I want you to be eating, some grains, some complex carbohydrates, and have a little bag of carrots, and then they're going to have like a protein shake in the afternoon, like before they go practice. Then right after practice, they might have another supplement shake. And they're going to have a dinner, and then their dinner will be like 6 or 7 o'clock, and then maybe about an 8 o'clock snack, no ice cream, but like an actual heavy protein, lots of nutrition snack. And they're going to basically have like 7 or 8 meals per day, and their caloric intake for that 24-hour period might be 4,000 to 5,000 calories, but they're quality calories. They're spread throughout the day, so you don't see these monster spikes. That's how they would manage it. Okay, was there another question here?
Yeah. So which type is it, the one where you got low glucose levels in the blood? Because people say that, like, oh, my blood sugar is low, I need to eat something.
So blood sugar levels being low, so if someone's unmanaged diabetic, then oftentimes if they're having a problem, it's going to be because they have too high a sugar in the bloodstream, and the cells are not getting the sugar, so they need to deliver insulin. If someone says, oh, I'm hypoglycemic, it's usually in between meals. Does that make sense? Mm-hmm. Like you're basically in a fasting state. So that would be hypo. So hyperglycemic is after a meal, you have a lot of sugar in the bloodstream, and you need to bring it inside the cell. But hypoglycemia is usually like, maybe right before lunch. You're like, oh man, I'm really hungry. I have an 8 o'clock class, and now I'm hungry because I skipped breakfast. You're probably hypoglycemic, meaning blood sugar level is quite low. Does that make sense? Did I answer your question?
Is there a type, is that a type of diabetes where their blood sugar is way too low?
It can happen with either in between meals or a normal person too, quote unquote normal, someone who's not diabetic. Right? All of us, when we wake up in the morning, probably have a blood sugar level in the 70s, just because, and so you're hypoglycemic, and you wake up hungry, whether you're diabetic or not diabetic. All right, let's take a break, and then we'll come back and we'll move into renal and liver.